6. Let's go ahead and get started. Good morning. Welcome to this educational webinar for the Oregon Health Policy Board and our Cost Growth Target Advisory Committee and any other committees of the board that are listening in today. I'm Sarah Bartleman with OHA. I'm the Cost Growth Target Program Manager, and I'm joined by Zachary Goldman, who's our healthcare cost economist. And we are going to tag team this presentation today. We're going to talk about our healthcare cost trends report, looking at some data from 2013 to 2019. And we're going to walk through the report in detail and just provide a little more grounding and extra time for Q&A about the report as we go through. Before we get started, Oscar, do you have any opening remarks that you would like to provide?
I'm good, Sarah. Thank you so much for the opportunity, though. But if other members who've been more involved with this are wanting to provide some comments, be glad to hear from them.
Great, thanks. Board members, any opening comments?
I'm very excited for this report and for kind of this effort, and I feel like delving into what is driving costs in our state is so critical to considering what are the appropriate policy solutions that we need to do to really get where we want to go in terms of having affordable quality healthcare for all people in our state. And so I'm really excited and appreciate the work that went into this, and happy that we're doing a deep dive into it today, and hope that it can be very informative in thinking about solutions we need going forward. So thank you for the effort.
Great, thanks so much. Okay, next slide, please, Madeline. So a couple quick housekeeping notes. We are recording this webinar. The recording will be posted online. We will also post the slides online on the board's website, so that will all be available shortly. Because this is an educational webinar, we are not conducting any policy board or cost growth target advisory committee business today. This is just an informal meeting. It is open to the public, but we are not holding a public comment period. And the chat is open. So if you have any questions or comments, you are welcome to drop those in the chat. Zachary and I are going to stop for questions periodically, but to manage time, we'll see how that goes. So please feel free to drop questions in the chat and we'll get to them, or any comments or reflections. Hopefully leaving the chat open will not backfire too much on us with the discussion, but that is open. So I think those are all of our housekeeping notes. So let's jump right in. Next slide, please. So this is our Cost Growth Target Program annual cycle. Our program is charged with measuring the cost of healthcare. How fast is that healthcare spending growing in Oregon year over year? And every year we'll measure that performance statewide about and relative to the cost growth target. But also, really importantly, next slide, we need to drill in on analyzing what the cost growth drivers are. So what is driving cost growth? What is underneath the hood, if you will? And as part of our cost growth target program, we have a data use strategy, and we are looking at producing routine analyses that pinpoint leading opportunities to reduce healthcare spending. Those opportunities might be things that the state could do, state level, whether that's agency work, small p policy, or whether that's legislative, big P policy. There are also opportunities that payers, purchasers, and providers can all take to reduce some of those cost drivers. So this report and this data we're going to present is part of this data use strategy, this part of our program cycle, really understanding what is driving cost growth. So next slide. Back in July, we published a new report. You might have seen it, Healthcare Cost Growth Trends. Next slide. There was quite a bit of media coverage locally about this report. A couple of the examples here. There was a Think Out Loud piece that Jeremy Vandehay, our Director of Health Policy and Analytics, was on to discuss a couple weeks ago. There was also quite a bit of coverage really highlighting the large jump in healthcare costs over this 6-year period, and really highlighting that rising prescription drug prices or pharmacy costs were one of the main drivers. Next slide. At the August policy board meeting, we reviewed the key findings from the report at a very high level. We shared some of the cost growth target committee discussion. Our cost growth target advisory committee also had reviewed the report in their July meeting. And then we started to make some space for policy board member reflections and discussion about what this means for us and where we go. We ran out of time for questions and discussion. There is a lot of content in the report, and there was a request to have some additional time to review and discuss what is actually in this data. So today we wanted to go back through the key findings and some of the data in the report. We'll present a little bit more detail than we did at the board meeting, and there'll be more opportunity for questions about the analysis. Next slide. So we're going to walk through the report in, go back one, sorry. We are going to walk through the report in order. There are 3 chapters in the report. We'll take them one at a time. The first chapter talks about healthcare cost growth in Oregon compared to inflation, income growth, wage growth, cost trends by market. The second chapter talks about cost growth for the 6 major service categories. So we'll define those and talk about what cost growth looks like in those service categories. And then the third chapter brings that all together. So if we look at what the primary drivers of healthcare costs are in each market, so what is the sort of number one contributor to those increases, will help tease that out a little bit. Next slide. So just a little bit about definitions. We look at reports by market, and when we say market, we mean Medicaid, Medicare, and commercial. And when we say service categories, we're talking about inpatient, outpatient, those are hospital-based services, professional services, emergency departments, pharmacy, and other, which is a little bit of a catch-all, and we'll get into more detail when we get to chapter 2. Next slide. One more note on methodology. So when we're talking about markets, when we're talking about Medicare here, Medicare includes Medicare Advantage plans as well as traditional Medicare or Medicare fee-for-service. Medicaid includes our CCOs, our coordinated care organizations, as well as Open Card or Medicaid fee-for-service. On our commercial side, we have our public employee plans, PEB and OEB, as well as all of the fully insured lives and some of the self-insured lives. Our data source is Oregon's All Payer, All Claims database, or APAC. So this is a claims-based analysis. We are only looking at claims-based spending. We're looking at 2013 to 2019. We are looking at allowed amounts when we're talking about spending. So allowed amounts are how much the health plan paid for the service or the procedure, as well as any amounts that the member might have paid. So cost sharing, co-pays, that type of thing. We are not looking at administrative costs, so profits, administrative spending, infrastructure type spending. And we are not looking at non-claims spending. So there's a whole other chunk of healthcare spending that is not reflected in this report, and just want to be upfront about that. We have other reports on that non-claim spending that we can point you to, but this is a claims-based analysis. And then finally, we have not adjusted any of this data for inflation, nor have we risk adjusted it in any way. So these are essentially the raw numbers. This is what sort of really happened each year, and we're not making any of those adjustments. So I think that is all of the quick background about what is in the report. Let's jump into chapter 1. Next slide. So we want to start with just a couple of the key findings up top, and then we will go deeper into each of the data behind all of these bullet points. So if we were tweeting our key findings, this is a framing that we used in July when we presented this as well. This was a really helpful exercise for me and for our team in thinking about what would we actually want to distill out of this report and think about crafting some of those social media messages. So if we were tweeting, we might say that between 2013 and 19, healthcare costs in Oregon grew at an average of 6.9% annually, which was faster than the national average, about 4% every year. Between 2013 and 2019, increases in healthcare costs in Oregon grew faster than inflation and medical inflation, and far outpaced increases in income and average wages. And we'll talk about each of those data points in a minute. And then finally, in that time period between 2013 and 2019, Medicare per person costs in Oregon grew at 58%, commercial costs grew 45%, and Medicaid costs grew the least at 32%. One more note that I want to flag before we jump into the graphs. We're going to bounce back and forth between talking about annual growth. So what was that percent increase or that growth in a given year, as well as cumulative growth over all 6 years. So that last bullet point, Medicaid costs growing 32%, that's cumulative growth versus average annual. So we'll try to clarify when we're switching between those two types of calculations. And let me kick it to Zachary.
Thanks so much. Good morning, everyone. I'm Zachary Goldman. Let's go to the next slide. So let's dig into the data. So Sarah provided the high level, the tweetable takeaways, if you will. Let's start on the left-hand side. So this is per person percent growth per year in Oregon. The blue line here is the Oregon story. The gray line is the US national average. So back in 2014, the annual growth was 7.6% compared to national 4.3%. Now there's kind of a sort of a downward trend here, but the important thing to take away is every data point here is higher than the national average, which is a little troubling. On the other hand, and let's look over to the right, in terms of the dollar amounts per person healthcare spending in Oregon are lower than national average. Now it's important to note, there's a kind of a methodological note here. These are taken from two different data sets. The blue line, as Sarah was talking about, is from our all payer, all claims database. The gray line is coming from CMS, the Centers for Medicaid and Medicare Services, and that's capturing kind of national healthcare spending. There's different inclusion and exclusion criteria there. So I wouldn't put too much stock in this, but on its face, Oregon is spending a little less than the national average. And we're actually going to kind of dive deeper into that notion in the future, in a future report, looking at CMS data. Okay, let's go to the next slide. So let's look at that left-hand side, but blown up a little bit here. So this is average annual per person healthcare cost growth, 2013 to 2019. The dotted line is let's pretend we were in a world in which the sustainable healthcare cost growth target launched in 2013 or 2014. That's what that dotted line would be, the 3.4%. The takeaway here is that every year's worth of growth exceeded that 3.4% target in the past. Let's go to the next slide. Okay, so let's kind of do some different comparisons. Same time period, 13 to 19. The blue line here is cumulative total per person healthcare costs, all markets combined. So Medicare, Medicaid, and commercial are wrapped up in that. The kind of yellowish mustardy color, 31.5% cumulative growth indexed on 2013. That's per person income in the state. And then compared to the green line, 21.5% average wages. So clearly healthcare costs per person are exceeding much faster than per person income as well as average wages in the state. Let's go to the next slide. Let's do a different type of comparison. Let's look at healthcare costs compared to inflation indicators and even another flavor of inflation called medical inflation. So again, that darker blue line, 49%, that's per person healthcare costs. Medical inflation typically trends higher than inflation. So that's the 17.2%. And then consumer price index inflation, which is kind of the most common indicator used, 9.7% growth from 2013 to 2019. Inflation is now in the news, obviously, but we're kind of stopping at 2019. So this is before that kind of inflationary pressure was really as salient as it is today. But even then, 17.2%, 9.7% compared to 49%. So again, per person healthcare cost growth really just kind of completely eclipsing other measures of inflation in Oregon. Let's go to the next slide. So now let's stratify by market, because commercial, Medicaid, Medicare provide different healthcare services. They serve different people in Oregon. Very different kind of risk profiles is the wonky term, but all that to say different people have different types of coverage. Medicare, for example, serves folks 65 years and older, as well as folks with disabilities. So that's a different population than some of these other markets. So let's dive in here. The first takeaway here is at the top, you have a dark red line. That's the Medicare trend, 57.5% growth cumulatively. So indexed on 2013, all the way to 2019, 57.5%. The blue line is kind of statewide average, so all three markets combined as an average. The orange is commercial, and that's cumulative growth 45.2%. And then the Medicaid line growing kind of at the lowest at 32.4%. We're going to keep these colors throughout the presentation. So Medicare is always going to be red, orange commercial, and green for Medicaid. Let's go to the next slide. Let's look at kind of the dollar amount, not just the percentage growth, but the dollar amounts. And this is interesting too. You can see Medicare dollar amounts much higher. Unsurprisingly, utilization is higher. The intensity of services are often higher for individuals with Medicare coverage. In 2019, the average per person healthcare cost dollar amount was over $11,000 for a Medicare individual with Medicare. Compare that to commercial, was about $5,000, a little over. Compare that to Medicaid, which is $3,600 in a given year. So you can see kind of some bumps, particularly for Medicare, really started to go up in 14, 15, and 16. And then the others are relatively smooth, some bumps here or there. And we're going to get into some different types of volatility. A reminder, this is only the dollars associated with claims. Sarah mentioned this at the top. So this doesn't include administrative costs and other spending that doesn't exist in the claims data. For there's a lot of research out there saying, Medicare is more, has a lower admin cost than maybe commercial, and how does that compare to Medicaid? So all those administrative costs are completely outside of this. This is just the claim spending. Let's go a little deeper. Let's go to the next slide. And here's where we get to some kind of a little more volatility. One more slide. So here we're going to look at the annual. Now we're not cumulative anymore. We're looking at annual growth per person healthcare costs by market. So there's a lot going on here. So let's distill this. Let's start with the orange commercial line. Okay, so big jump from 2013 to 2014, and then a decline in 15, and then it kind of sort of stabilizes. 2014, as many of you know, was the full implementation of the Affordable Care Act. This resulted in numerous policy changes. There were essential health benefits that were mandated. More individuals moved to the individual market with subsidies. So just a lot of change happening in 2014. Similarly, a lot of change happening in the Medicaid space in 2014 because that was the expansion of the Oregon Health Plan. So we're going to talk about the number of people in a second here, but this is just total spending. Interestingly, per person spending for Medicaid actually went down, and we'll talk about why at the next slide. And then it went up, and then I want to place a placeholder in your mind for 2017, 2018. Notice how Medicaid, that green line, goes up a bit in 2017, 2018. So we're going to talk about why in a moment. So the takeaway here is that there have been some shocks to the market, and so that resulted in some volatility of the annual growth per person percentage change. Let's go to the next slide. Okay, so let's start actually with the Medicaid, the green line. I remember I told you to put a placeholder for 2017, 2018. Notice that there's a pretty significant dip, maybe 10 percentage points starting in 2017, 2018. So huge expansion in 2014, right? The expansion of Oregon Health Plan and the Medicaid expansion as a result of the Affordable Care Act. Then it kind of grows a little bit more, but then starting in 17 and 18, it dips down and then stabilizes. So in 2017, 2018, there was a robust process within the Oregon Health Authority to redetermine folks in terms of their eligibility for Medicaid. This was kind of a result of, we had a huge surge of enrollment, and then we had to kind of catch up and redetermine individuals. That resulted in some individuals no longer qualifying for Medicaid, or rather, that resulted in the determination that some individuals didn't qualify for Medicaid, and therefore the number of people went down. In a little bit, we'll talk about how that affected total spending, because there was a material impact there. So that's the Medicaid story. The commercial story is really interesting as well. You'll see in 2014, a slight decrease, only 2%. I'm looking at the orange line. Slight decrease of number of member months of people enrolled. But then in 2015, 2016, a really big steep drop off of individuals. That's because in 2015, the US Supreme Court decided a really important and impactful case called the Gobet decision. And that resulted in some carriers with what's called an ERISA plan no longer being required to submit data to the All Payer All Claims database. This wasn't just Oregon, this happened to every state in the country. So 2015, 2016, 2017 had a noticeable drop off of number of claims and number of individuals in the claims database as a result of that Supreme Court decision. So that is what it is, but we can still kind of look at longitudinal trend from 16, 17, 18, 19 and forward. So a lot going on, right? There was a lot happening between 2013 and 2019, and it's important to understand all of that as the backdrop.
Let's pause there for a second. There are two questions in the chat that I want to address. One question is about why we excluded administrative costs and why that's not part of this analysis. And that's actually a pretty easy answer. It's because administrative costs like that are not in the all payer claims database, and this was a claims-based analysis. However, the cost growth target program will be working on some additional similar reports that use a different data source that are more inclusive, a more inclusive look at spending that will include some of that administrative costs, the profit, that will include the non-claims based spending as well as the claims. So future reports and discussion of this type of data or this type of analysis will be a little more all encompassing, and we'll be able to tease that out more, but it just isn't in the data source that we used for this analysis. Second question was about if we'll be looking at how the population changed in Oregon. So essentially kids versus adults. Are there more kids, more older adults in Oregon? And that's a really great question. And we did not do that as part of this analysis. I think that is something our team could take back and poke around at and talk about how that changes, as well as just the enrollment changes by market. I think that's a great point in terms of costs. For example, we know newborns, infants are a lot more expensive than toddlers, and we know older adults tend to be more expensive. And so that definitely is a factor in what's driving cost growth, but we didn't specifically look at population changes in this analysis. Okay, one more question coming in. Thank you for keeping these in the chat. It's really helpful. Can we say a bit about the reasons for focusing on costs rather than prices? So I think this is going to sound like a little bit of a facetious answer, I think, but I think we are looking at where the cost growth target program, we're sort of charged with looking at overall healthcare cost growth in the state. So we're looking at total spending. That's where we start. Then this is our sort of foundational analysis. Then we start unpacking it. So today we'll look at by service category. Future reports that our team is working on is looking at prices. What's driving cost growth? Is it prices? Is it utilization? Is it population changes? Are people sicker? Are people receiving a higher intensity of services? So maybe more aggressive treatment or newer treatment modalities versus older treatment modalities. All of those kinds of things are things that we want to look at. So it's not that we chose to look at spending instead of prices, it's we're looking at spending first, and we'll look at some of those other things later. Okay, I'm going to move us into the next section because I just looked at time and realized that we should maybe speed up a little bit. So let's go to chapter 2. Next slide, and then one more slide. So in chapter 2, we're going to start looking at those costs by service category. So our key findings here: total per person healthcare costs in Oregon were $6,713 in 2019. Most of those dollars are coming from inpatient hospital services, about $1,800, and professional services like doctor's visits, about $1,700. Between 2013 and 2019, per person pharmacy costs grew cumulatively by 116%. That's more than any other service category in Oregon that we looked at. And per person pharmacy costs were about $1,365 in 2019. The 4 largest service categories, inpatient, professional, outpatient, and pharmacy, all grew faster than 3.4% each year between 2013 and 2019, and per person pharmacy costs grew the most, almost 14% each year. So we will talk about all of those. I'm just going to give a real quick grounding on the next 2 slides into what these service categories are. So next slide, please. So the first service category is inpatient care. So that is hospital-based care after someone has been admitted. If someone is in the emergency department, that's in the emergency department category. This is only folks who have been admitted. This would be things like childbirth or an inpatient surgery. It also includes any costs for drugs that were administered to patients who were admitted in the hospital. Outpatient care, those are services that are provided in clinical settings. So any services that are rendered to patients admitted in the hospital or in the inpatient, and then this would be any hospital-based outpatient care. Professional services are services that are provided by independent or hospital-affiliated physicians, nurse practitioners, and other providers. It includes costs associated with diagnosing and treating patients' medical issues. And I know there can often be some questions about what's the difference between outpatient care and professional services. And it's a little confusing. It tends to be somewhat based on location. So if you're in an outpatient clinic that's sort of hospital affiliated, and then professional services can kind of be across the board, and it's more about who is providing those services. It's a really unprecise answer. There's more details in our methodology write-up, but there are some differences in how we've split those costs out. Next slide. And then 3 more service categories. So pharmacy. When we're talking about pharmacy here, we are talking about retail pharmacy. So these are drugs that are obtained at the pharmacy, drugstores, or other locations. If the drug was administered by a physician, so if you go to the doctor's office for an injectable drug, those costs are not included here. They would be included in one of the other categories. This is really only that retail pharmacy. Emergency department services, pretty much what it says on the tin. If a visit starts in the emergency department, but then results in that person being admitted to the hospital, all of those costs are reflected in the inpatient category. And then finally, other, that is everything else. So that includes medical transportation, like ambulance rides, laboratories, and anything else left over that didn't fit into one of those other categories. Okay, and back to Zachary.
Thanks, Sarah. So let's dig into the cost trend. Here we're looking at per person healthcare costs by each service category. The most expensive one is inpatient. Back in 2013, it cost $1,469, and then in 2019 that had increased to almost $1,800. Professional services is the second most expensive. Outpatient was the third, but actually as of 2019 was the fourth, because pharmacy, you'll notice, kind of nudged it away. So pharmacy was the fourth most expensive at $633, but elbowed its way into third place, $1,365, as more expensive as outpatient. The other 2 categories, emergency department and other, are relatively small compared to the other service categories, but there's some kind of up and down there. One thing to note here, these service categories, they're designed to be collectively exhaustive, so it captures everything, but also mutually exclusive. So a given dollar isn't showing up in more than one category. Okay, let's go to the next slide. So this is the same kind of snapshot, but just a different data visualization here. So you can see kind of how these things stack up. So the total, this darker black line, total spending from 2013 to 2019, 4,506 all the way to 6,700. Pharmacy had significant growth. Emergency department had second highest growth. So you can kind of see how these things cumulatively kind of stack up. Let's go to the next slide. This is one of my favorite visualizations here, and why it's so important is because it shows each given service category and the growth from 2013 to 2019. Again, if we had implemented a sustainable healthcare cost growth target at 3.4% back in, say, 2013, we'd be comparing some of these service category growths to that 3.4%. And notably, every one of those categories would have exceeded it, or did exceed 3.4%. Pharmacy kind of steals the show here at 13.9% per year. This is annual. This isn't cumulative. So per year, pharmacy was growing almost 14% every year. Professional services 8%, 7.4% for outpatient. And inpatient, although the lowest at 3.5%, still exceeded the healthcare cost growth target. So it's easy for pharmacy to steal the show, but it's important to note every service category exceeded the target that we're now working with, 3.4%. Now that target wasn't in effect, but for for a comparison, we can use it. Let's go to the next slide. Okay, so let's dig into each service category. And for the sake of time, and I want to encourage more questions coming in, I'm going to kind of quickly go through these because I think the last section of the slide deck is even more interesting, and I think you all will find that too. So inpatient, the story here, unsurprisingly, Medicare has the highest costs. So we have the dollar amounts on the left-hand side. Medicare has the highest dollar amounts. On the right-hand side, we have total growth, total cumulative growth from 13 to 19. So inpatient for Medicare grew at 25.4%. Compare that to commercial and Medicaid, which only grew, 2 and change percent, and much lower dollar amount. So that's inpatient only. Let's go to the next slide and look at outpatient. It's a similar story. Medicare pretty high up, commercial in the middle, and Medicaid at the bottom. I like looking at both the dollar amount on the left-hand side, but also the total growth, total cumulative growth from 13 to 19 on the right-hand side. So Medicare grew 53.5%, commercial even more at 60.6%, and then Medicaid the lowest at 47%. It's important to note here that because we're talking about a percent growth on a smaller dollar amount is smaller than a percent growth on a larger dollar amount, right? So a 50% growth in Medicare at $1,500 is more dollars than a 50% growth of commercial at $700, right? That's just kind of how it works, but it's still helpful to compare these things against each other. Let's go to the next slide. Let's talk about professional services, which is another biggie category in terms of total spending. Similar story, but a little more kind of fluctuation here between 14 and 15. There's a lot going on. Part of that for the commercial line in orange, part of that could be that Go Bay Supreme Court decision that we talked about. Medicare is an interesting situation. We need to dig deeper into what's going on in 14 and 15 as to why that's spiking, but there's a bit of a jump there. But kind of similar trend here. What's interesting is that commercial actually has the highest percentage growth at 75, almost 76%, which is pretty large. Let's go to the next slide. And this is the last one that we're going to show for this, pharmacy. So we talked about before how pharmacy was stealing the show at really high average annual growth rates from 13 to 19. Here, it's Medicare pharmacy. We can clearly see that the Medicare pharmacy spend is behind the wheel here of driving this car. Huge increases from 13 to 16, and still some pretty steep increase from 16 to 19, although flatter than what it was. So there's a lot going on here in kind of the early years of this time trend. Commercial still has 92.8%. That's still pretty high. Even Medicaid, almost 80%, 79%. So pharmacy for sure growing across all of these markets. Let's go to the next slide. I'll kick it to Sarah.
Yeah, let's back up one slide. I want to just say something that we probably should have said up front. When we're talking about per person costs, this is the average. So we take all of the dollars spent in a given category or a given market, and then we divide it by how many people there were in that market. So this is an average. Certainly, it's a really helpful way to benchmark this. It's a really helpful way to talk about this and provide these comparisons, but this is the average, and everyone's utilization and everyone's costs are unlikely to be exactly the average. Mine might be a little higher, yours might be a little lower. So recognizing that there are some folks who have this is going to not be reflective of every person's costs individually. This is just the average. This is just a way to look at the data in a really standardized way. There are some folks who we know have really high healthcare costs, and that they have conditions that require really expensive treatment, and that's all included here. They're pulling the average up. We have some folks in the data. There are some people who aren't utilizing healthcare at all, and that might be due to access barriers. They might not be able to get healthcare that they need. They might not be able to afford it, or they might not actually need it. That is also true. Sometimes you just don't need healthcare in a given year. And so that pulls the average down. So I just wanted to reflect that all of this that we're talking about on a per person basis, but it's an average, and there's a lot of individual nuance that's reflected across that data. And we're kind of rolling it up. I don't see any questions about this section, so let's keep going to the third chapter. So as I said, this is the chapter that's going to put all of this data together and look at the cost growth drivers specifically for each market. So key question for this section, what drove the healthcare cost growth in each market in Oregon between 2013 and 2019? In the commercial market, cost growth was driven by professional services. In the Medicare market, that was driven by pharmacy, mostly for that last graph that Zachary just talked about. And then cost growth in Medicaid was also driven by pharmacy and to a lesser extent, professional services. Okay, Zachary, back to you.
Here we have, before I jump in, Dr. Santa's asking, are dual eligible folks in Medicare or Medicaid or in some degree in both? So here we split individuals up actually. So a given individual with both Medicare and Medicaid coverage, often known as a dual enrollee or dual eligible, we isolated the different services that were paid for by different payers, either Medicaid or Medicare. So that's consistent across all years. But for an individual, it's from the perspective of a single individual that has both coverage, it would be a little chaotic because you'd see, some services would be falling in this bucket over here and other services would be falling in a different bucket. But because we're consistent across years, we feel like that allows for a reasonable trend. I'll also note,
the short answer is dual eligibles are in both the Medicaid and the Medicare trend lines here.
Right. Yeah, mutually exclusively both. Yeah. Also, just a note about pharmacy, because we're going to talk more about pharmacy in these next bubble graphs, which are really fun. These are not considering pharmacy rebates. So rebates are kind of a complicated mechanism in which entities purchasing drugs, plans, insurance carriers receive a rebate for certain medications that they're buying. Our data doesn't reflect that. So that's just a known limitation. It is what it is. When we have more data from the cost growth target work, we will have more of a sight line into that. So that's going to be interesting as well. So stay tuned for that. Okay, let's jump in. Let's go to the next slide. So let me first orient you to how we're going to read these, because these next graphs are a little complicated, but once you get it, hopefully it's really meaningful and super interesting. Okay, let's start on the left-hand side, the vertical. So the vertical shows dollar amounts. So the per person spending in 2019. So the higher the bubble on the graph, the more expensive in terms of dollars it was in 2019. The horizontal, the flat axis here is cumulative growth from 2013 to 19. So if there's a bubble that's really close to that left-hand side, not much growth there. But if it's really far to the right, then that means it has high growth from 13 to 19. So in other words, if there's a bubble that's really high up and really far to the right, that means it had a lot of growth and is expensive, right? So this is the difference between cost and cost growth. Cost is the up and down, cost growth is the left to right. So that's the first piece. The second piece though, and this is kind of fun, the larger the bubble size, and you'll get it once we see it, the larger the bubble size, that means that particular service category was more responsible for total per person cost growth. So that was more in the driver's seat of total growth from 2013 to 2019. Okay, so that's kind of the introduction. Let's jump in, and I think you'll get it when you see it. Let's go to the next slide, and let's start with commercial. Commercial market. Here you see a cluster. Things are further to the right. There's only really one thing all the way on the left, and that's inpatient. So that means inpatient didn't really grow all that much for commercial from 2013 to 2019. And it was maybe in the middle of the pack in terms of up and down, maybe that's $900 or so. But the real takeaway here is professional services. Here, they clearly had the highest per person cost at $1,657 because they're the highest up. And pharmacy, because it's the furthest to the right, had the largest growth at 93%. When you look at the bubble sizes here, professional services is for sure the largest bubble. So it's the growth in professional services that is driving most of the overall cost growth in the commercial space. Pharmacy is pretty large too, although smaller than professional. And then outpatient is sizable. Inpatient and ED are very small relative to the others. So takeaway, professional services were the highest cost. Pharmacy was the highest cost growth. And in terms of overall cost drivers, professional services followed by pharmacy in the commercial space. Let's move on to, Yeah, go
Sorry,
ahead.
can we
Yeah,
go back to commercial? I want to editorialize on this. I think one thing that some folks might have been surprised by, Madeline, go back one slide, please, was that the inpatient is so low. I think as we've been looking at, or not low, but that the inpatient bubble is where it is on this graph. I think as we've been looking at cost growth target work in other states and some of the data that they are putting out, they are seeing a much larger, a higher cost and larger growth in inpatient services. And I think we were a little surprised when we saw this. So I think want to reflect a little bit non-bindingly on we also know that one thing that's been happening with hospital services is a shift from care being provided in inpatient settings to care being provided in outpatient settings. So it is possible that some of what's happening here is that more and more services are being provided that are being captured in the outpatient bubble and in the professional services bubble rather than in the inpatient bubble. So sort of where care is delivered is shifting, and that's also showing up here in how we're capturing the costs. So I just wanted to provide that comment because I think we tend to think of hospital costs as really expensive, and certainly they're a large driver in some other states, but that's not what we're seeing here. And some of that might be due to that shift in where care is delivered. Okay, sorry, Zachary, back to you.
no, that's great. That's great. And if a reminder, if folks have any questions, feel free to send them in the chat and we will respond to them live on the fly. Okay, let's jump into Medicaid. Same concept here. Price is on the left, growth is on the bottom. Different than commercial, right? They're lower, so they're lower cost. All the bubbles are kind of 1,000 and lower. They're also a little bit more spread out. There's more bubbles kind of on the left-hand side, so cumulative growth maybe is a little smaller for some of these sectors. Interestingly, inpatient is higher than it was for commercial. So inpatient had the highest per person cost, 1,350. Yet it didn't really grow very much, right? Only a few percentage points from 13 to 19. So that's why it's really close to that vertical axis. High cost relatively, but not a lot of growth. Compare that to this other category, all the way on the right, not much cost here at all, only $138, which relative to the others is very small, but it grew the most at 119%. Now there's a lot of kind of, interesting things in here. This is like ambulance, ambulance rides, independent laboratory costs. There's just kind of other healthcare services that don't fit nicely into the other categories. It's a really small category, but for Medicaid, it grew a lot, but it was only $138. But if you kind of just look at this in a second, you can see, oh, well, pharmacy and professional services, clearly those are the two largest bubbles. That's because those two are really driving the overall cost growth story here. Those service categories are responsible for the most cost growth. Outpatient and ED is smaller, although there's some cost growth there too. 45 over 60% growth from 13 to 19. I think that's all I have for Medicaid. Sarah, any thoughts on the Medicaid bubble chart?
No specific thoughts. Want to pause just a second for a couple of questions that are coming in. I think, again, we are looking at the difference here between cost and cost growth. And there's one more layer. There are many more layers, but there's one more layer under the hood that we are not looking at all today. And that's what is driving that. Is it price? Is it utilization? Is it demographics? Is it intensity? That is one of the next analyses that we're working on. And we're hoping to publish a report that sort of unpacks this all even more to dig into that price versus utilization. Prices go up, utilization goes up and down. Those are both factors, absolutely, in what's behind this. We haven't specifically disaggregated that for Oregon, so I wouldn't want to say definitively we know the answer. I will say that all of the national data and a national analysis that has done that, the driver is price. It's prices increasing, not utilization increasing. And I can share some references to some other studies that are looking at this nationally. We will do that for Oregon. That's one of our next steps that we're working on, hopefully for later this fall. So we'll be able to document that exactly. But I think it's a totally fair question to wonder if it's price or utilization. Both are changing. It's a very dynamic space. But sort of nationally, the accepted answer is it's mostly price that's behind this.
Yeah.
Okay, sorry. Go ahead, Zachary.
Let's just go back to Medicaid for a second. And let's see, Dr. Santos is mentioning that there's some research out there that he's seen that there's evidence that Oregon is relatively low intensity, low utilization, especially in Medicare. I appreciate that. Is there any sense how significant of a difference the inclusion of pharmacy rebates could change these charts? Yeah, so that's a known unknown. We don't know the influence yet. We'll look. We're very much looking forward to seeing that. So at this time, don't know how that would change the story. So we'll find out once we get that data and can look into it. The other point I want to make about Medicaid is remember earlier in the presentation, we talked about that redetermination process in 2017, 2018 that resulted in fewer individuals, relatively fewer, it's about 10 percentage points drop of members with OHP. That was in 2017, 2018. Interestingly, costs per person costs actually went up a bit. So fewer people, but a little more costs. Why? That's because the redetermination created a situation in which folks that really needed services were very much speculation, but we're very much more likely to kind of go through the process of submitting income stubs or submitting whatever else they needed to continue to qualify for Oregon Health Plan. Whereas individuals who maybe weren't using services, even if they're still eligible, maybe they didn't follow through with some of the information gathering that OHA needed from them. All that to say, on net, the individuals who were remaining were a little more costlier, as it were, that they needed more services. So that's the kind of dynamic between utilization and overall spending and that kind of risk profile that we talked about at the top. Okay, now let's jump to Medicare. Okay, so Medicare, yet a third story, right? This is very different than the other two. So inpatient, clearly the highest cost, the highest bubble, relatively low growth, right? Similar to the other two, but much higher. Inpatient costs at the highest per person cost at about $3,500, but really the lowest growth at only 25%. On the other hand, pharmacy, way on the right-hand side, large bubble, medium height cost. It's about the same as outpatient professional, but the growth is the most at 185%. So pharmacy clearly driving the overall spending because of its bubble size. But inpatient, outpatient, and professional are all kind of tied for second here. So they're also influencing overall cost growth to a pretty high degree, but really eclipsed by that pharmacy spend. Emergency department and other are relatively inconsequential here. They're relatively low spend and somewhat low growth, although ED isn't super low growth. It's kind of in the middle of the pack. So this is the Medicare story. Again, very different risk profile, different utilization trends, different services that are needed, even different services that are covered, right? In terms of what Medicare is willing to pay for versus commercial versus Medicaid. They're all a little different.
Right. I'm going to take it back from there. We have a couple more questions, and then I want to talk about next steps and what we're going to work on and where you can. So one question is, has there been a cost growth target for Medicaid for a longer period of time? And this is both a yes and no answer. So Medicaid has had various limits on cost growth, and it's also been 3.4%, so the same value. For a number of years, since 2012, 2013, our earlier Medicaid waiver work. That is different than how the new cost growth target works. Medicaid is now also accountable to the new cost growth target program and will be measured and held accountable in the same way going forward. So it's not quite accurate to say that it's been held to the cost growth target sort of exactly as is, but we have been looking at controlling costs in Medicaid, and we've been measuring that in a variety of different ways. I just added one more link to the chat. We put together a little 2-pager as part of this report that explains some of the different ways we look at Medicaid cost growth. Because Medicaid has both state and federal funding, there are some limits on essentially how much budget there is available to pay for Medicaid. And we measure that relative to a cost growth target. But then there's also how much was actually spent on Medicaid services. And that's what we're measuring here. So sort of looking at different parts of the budget and the funds flow in the healthcare system. But we have been measuring that for Medicaid and looking at various cost controls in Medicaid for about a decade. So yes. Comment about data visualization. Thank you. Yes, more accessibility in color noted. Thank you, Stick. Okay, let's go ahead. I want to go to slide 40, Madeline, please, and just talk about next steps. So we have a few more minutes for questions, but I wanted to flag that at our cost growth target advisory committee meeting on September 9th, we are going to continue talking about pharmacy costs and the pharmacy cost drivers. We're hoping to provide a little bit more analysis and look at different subcategories of pharmacy. So what types of drugs are we seeing this growth in? What's happening where? We know there are a number of questions about things like brand versus generic or physician administered drugs versus retail drugs. So we're starting to dig into all of that. We're also working with our colleagues at DCBS and the Prescription Drug Affordability Board and the Prescription Drug Price Transparency Program. They are also really charged and responsible for looking at pharmacy costs, cost drivers, understanding the impact of pharmacy rebates, understanding our opportunities to influence pharmacy costs. So more conversation on pharmacy coming up September 9th. We had a number of questions that the policy board and the advisory committee members asked. So more detail, more clarification. Zachary and I have both hinted at some of those pieces that are coming soon. So we're hoping to provide more information in September and again later this fall as we dig in and provide more details. We are also looking at another report that will look at 2018, 19, and 20 that uses our different data source, that uses our cost growth target data submission, not our all payer, all claims data. So we'll be able to look at things like non-claim spending, the impact of pharmacy rebates, administrative costs, profits. We're working on that report hopefully later this fall. So let me stop there. And are there any other questions that we want to try to get to? Not seeing anything in the chat. Any questions that people want to ask on video?
No question. I just want to say a comment about I really appreciated the presentation and all the data and how it's been presented. So thank you so much for for going through the report this way.
Thanks, Oscar. Glad it was helpful. Kirsten, will the trends report coming in the fall also differentiate by payers? So I want to be careful with my language here. So what we presented to you today, we're calling that our by market, our market level analysis, Medicaid, Medicare, and commercial. The report coming in the fall will also differentiate by market. For the cost growth target program, when we're talking about payers, we actually mean the specific sort of named insurance plan. So MODA and Providence and Kaiser. And the report in the fall will not name it at the payer level, but starting next year, our reports will start reporting at the payer specific level and then also for large provider organizations. So we're going to continue to provide more breakdown, more granular reporting, and it will be identified in the future. But for the fall, it'll still be at that market level, Medicaid, Medicare, and commercial. All right, one more minute. Last questions, anybody? All right, Oscar, Kirsten, John, as board members, any closing comments?
Just appreciation for all the work that you're doing in this area and looking forward to seeing what the recommendations from the committee eventually get to. So looking forward to that. And yeah.
Yeah, and this is John. Great work. Lots of interesting issues that you're bringing forward, and keep it up. We need it.
We will come back with more data. All right. Thanks so much for joining us this morning, everyone. We'll talk to you soon.
Thanks
Bye.
all. Bye.